Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I'm the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time as I share with you some very useful tips which may prove handy in your line of duty. Welcome to part 72 of our pharmacotherapy MCQ series, Measuring in Toxicology. Our first question reads, Mrs. VCW, a 24-year-old female patient who attempted to commit suicide by ingesting acetaminophen, is admitted to your intensive care unit. Her initial 4-hour post-ingestion acetaminophen levels were 210 milligrams per deciliter. Some of her pertinent lab results include an AST of 445 and an INR of 1. The critical care team initiates an N-acetylcysteine infusion. They opt for the N-acetylcysteine regimen via the IV route, which has been infused for 20 hours of the 21-hour protocol. Our current labs include acetaminophen levels of 35 milligrams per deciliter. The AST has fallen to 300, while the INR has increased to 1.4. Now, Madam VCW is awake. She's alert and oriented with no complaints. So my question to you is, which of the actions listed below would be the most appropriate to take in Mrs. VCW's case now? Would you discharge her home? Would you transfer her to the inpatient psychiatric ward? Would you opt for N-acetylcysteine but at a dose of 100 milligrams per kilo over 16 hours? Or would you settle for N-acetylcysteine at a dose of 150 milligrams per kilo over 1 hour? I'll give you 10 seconds to choose the correct answer. So I would continue infusing N-acetylcysteine at a dose of 100 milligrams per kilo over 16 hours. Now, N-acetylcysteine therapy should be continued if there is evidence of hepatic injury defined as an AST significantly above normal, or if the PT to INR ratio is greater than twice the normal, or if encephalopathy is present, or if paracetamol metabolism is incomplete and paracetamol is still detectable in serum. Now, N-acetylcysteine is continued and the 100 milligram per kilogram dose over 16-hour infusion is repeated until there is no evidence of hepatic injury and until the paracetamol metabolism is complete. Now, restarting the protocol isn't appropriate in this clinical scenario at all. Now, while Mrs. VCW should likely have psychiatric care provided to her, in my opinion, it isn't the most appropriate intervention to transfer her to such a unit now. Now, Co-ingestion of anticholinergics such as diphenhydramine and opioids may slow down GI motility, and that may prolong absorption of paracetamol, distorting the interpretation of the peak paracetamol level. So always do your thorough inquiry to see what else the patient co-administered. Now, toxic metabolites of paracetamol, like the N-acetylp-benzoquinamide, NAPQ, which is produced from saturation of glucuronidation and sulfation pathways and induction of the CYP pathways, are commonly observed. So with all those many words, I would settle for C as the best bet. Let's move to the next question, please. And it reads, Master RDM, a 7.5-year-old boy, was exposed to lead paint at home. His current lead concentration is 50 micrograms per ml. His G6PD screen performed by your lab revealed a deficiency. So my question to you is, which of the chelators listed below would cause hemolysis, and should it therefore be used or should be avoided in Master RDM's case? Is it calcium sodium edtate? Is it saxima? Is it dimercaprol? Or is it DMPS? I'll give you 10 seconds to choose the correct answer. So dimercaprol it is. Now, while not contraindicated, dimercaprol should be used with extreme caution in patients with G6PD deficiency due to the risk of hemolysis. Now, since this patient of ours has blood levels that are less than 70 mics per deciliter, he should be treated with saxima or unithiol. Those would be the antidotes of choice. Now, depending on the clinical scenario, a risk-benefit ratio would be considered. For example, in the case of a significant lead encephalopathy with a compromised GI tract, it would be considered. Dimercaprol would be considered. Now, chelation regimens with dimercaprol shouldn't be interrupted, since abrupt cessation can cause redistribution of lead into the brain and other forms of soft tissue. I would like to remind you that dimercaprol may chelate other essential elements, so be very careful when using it. However, supplementation of iron isn't recommended in children due to nausea and vomiting. Now, close monitoring of iron levels is recommended when you're intervening, and just to emphasize that dimercaprol shouldn't be administered orally because of obvious reasons. Let's move to the next question, and it reads, Master JKL, a 4-year-old boy, accidentally drank a substantial volume of antifreeze which he found in his father's garage about half an hour ago, before his mother rushed him to your accident and emergency department. Now, my question to you is, which course of action listed below would be the most appropriate in the case of Master JKL now? Would you opt to call a poison control center hotline for advice? Would you do a urinalysis with Wood's lamp examination? Or would you administer activated charcoal with sorbitol at a dose of 1 gram per kilogram body weight orally? Or Would you administer charcoal at a dose of 1 gram per kilogram orally without the sorbitol? I'll give you 10 seconds to choose the correct answer. I would call a poison control center hotline and seek advice. Now both options C and D aren't appropriate, since alcohols including ethanol, methanol, ethylene glycol aren't absorbed by charcoal. Now additionally, as a result of possible intoxication, altered mental status, and the like, administration of activated charcoal to such a patient may carry an unacceptable high risk of aspiration and pneumonitis, so don't dare. Now, urinalysis or other urine toxicology screens rarely provide data for which action treatment plans can be created and aren't useful in toxic alcohol ingestion at this phase in care. It wouldn't be a priority. A urinalysis may be useful to identify oxalate crystals hours to days after ethylene glycol ingestion, but it isn't useful in the hyperacute phase, just as an emphasis. Now, the best initial management is to contact a local poison control center, as they can provide support or guidance for clinicians with the most current treatment recommendations. Now, toxic alcohols such as methanol, ethylene glycol, and even ethanol may cause an ion gap metabolic acidosis, while isopropyl alcohol doesn't cause a positive anion gap. Just as a by the way, I'd also like to remind you that treatment of methanol or ethylene glycol ingestion is alcohol dehydrogenase inhibition form the antidote of choice, which is formepizole, or we can even use IV ethanol. Now, formepizole, is a hepatic enzyme inducer, and it's also an auto-inducer. Just remember that. Let's move to the next question, please. And it reads, Mrs. TJP, a 47-year-old female, ingested toxic amounts of theophylline about 1 hour ago. Now, your critical emergency medicine team at the accident emergency department has mechanically ventilated her, and TJP is now sedated and has an orogastric tube with 2 gauge 18 IV catheters and a Foley catheter in situ. And the team seeks your guidance as a clinical pharmacist based at the accident and emergency department on how to approach theophylline ingestion, since many of them have no clinical experience with it. So my question to you is, which of the interventions listed below would be the most appropriate in Mrs. TJP's case now? Would you settle for glucagon 0.05 milligrams per kilo IV push, followed by 0.05 milligrams per kilo IV every 6 hours? Or would you settle for activated charcoal at a dose of 1 gram per kilo orally, followed by 0.5 milligrams per kilo orally every 6 hours? Or would you settle for the administration of sodium bicarbonate at a dose of 1 milliequivalent per kilo IV push, followed by 1 milliequivalent per kilo per hour IV infusion? Or would you administer 3 milligrams of adenosine via IV push, followed by 6 milligrams of adenosine via IV push? I'll give you 10 seconds to choose the correct answer. I would administer 1 gram per kilo of activated charcoal orally, start, followed by 0.5 milligrams per kilo orally every 6 hours. Now, multi-dose activated charcoal, which we abbreviate as MDAC, should be used in patients with life-threatening theophylline overdoses. Now, when available, the sorbitol-free dosage form should be used, given the risk of ischemic colitis when we use the one without sorbitol. Now, supraventricular tachycardia from theophylline overdose may be resistant to adenosine therapy, and if considered, should have the adenosine dose increased to 6 milligrams, followed by 12 milligrams, followed by 12 milligrams, to the higher dose of 12 milligrams, followed by 18 milligrams, followed by 18 milligrams. You require a higher dose. So this particular dose of 3 followed by 6 would not work. That makes answer D wrong. And sodium bicarbonate doesn't play a role at all, and it may worsen associated hypokalemia, and glucagon doesn't play any role in theophylline overdose either. Now, MDAC should be considered in cases where the drug dissolution is delayed, and should also be considered with delayed or prolonged release formulations when GI motility is decreased because of co-ingestants, or when reabsorption is prevented. Now, MDAC can be used in poisoning caused by tricyclic antidepressants, for example. It can also be used in the case of cyclosporine poisoning, in the case of carbamazepine overdose, in the case of dapsone, digoxin, nadolol, phenobarbital, phenylbutazone, propoxyphene, even quinine, if I remember well, the salicylates, and theophylline. It can be very handy in all those. So that's just a by the way to justify why B is our correct answer. Next slide, please. And the question reads, your emergency medicine consultant at your accident and emergency department initiated unfractionated heparin therapy in Mr. PLP, a middle-aged male patient. Shortly after, Mr. PLP developed intraocular hemorrhage. So my question to you is, which of the treatment options listed below would you recommend for PLP's case now? Would you choose to administer vitamin K? Would you set for idarucizumab? Would you administer protamine sulfate, or would you administer digibind? I'll give you 10 seconds to choose the correct answer. So protamine sulfate would be my choice. Now, protamine sulfate is administered in the case of emergency bleeding due to heparin administration. Remember, digibind is an injectable ship antigen binding fragment, which we abbreviate as FAB, and it is an antidote for digoxin, not heparin. And idarucizumab, which is Praxbind, is an intravenous injectable humanized monoclonal antibody, which is an antidote for dabigatran or Pradaxa toxicity. Now, vitamin K is used to reverse the effects of warfarin, Coumadin, so it would not be helpful in the case of heparin toxicity. So I would just like to remind you that 1 gram of protamine sulfate neutralizes 100 international units of heparin, and protamine sulfate can reverse low molecular weight heparins as well, e.g. enoxaparin, for example, but only about 60 to 75% reversal occurs. Since it is dosed sub-Q, with only part of the dose getting to the blood stream. Now, protamine sulfate can act as an anticoagulant at doses exceeding 50 milligrams. So never exceed the 50 milligram mark. Yeah, that should be your ceiling at all times when you are managing heparin overdose or toxicity. Sorry. Let's move to the next question, please. And it reads, Mrs. T.O.O., a middle-aged female patient, is rushed to your accident and emergency department following tricyclic antidepressant toxicity. She is having 6-second runs of ventricular tachycardia and her current pH is 7.55. According to the most recent arterial blood gas, that is. So my question to you is, which of the treatment options listed below would be the most appropriate for Mrs. T.O.O. now? Would you choose to infuse sodium bicarbonate? Would you administer hypertonic saline? Would you administer procainamide? Or would you do urinary alkalinization? I'll give you 10 seconds to choose the correct answer. I would opt to administer hypertonic saline. Now, hypertonic saline should be used since Mrs. T.O.O.'s pH is between 7.45 and 7.55. Remember, sodium bicarbonate is used to overcome the sodium blockade from tricyclic antidepressants and to increase the pH. It shouldn't be used if the pH exceeds 7.55. Now, urinary alkalinization hasn't been shown to be effective in the management of tricyclic antidepressant toxicity, and procainamide, just for information, is a class 1A antiarrhythmic medication which also blocks sodium channels during phase 0 of the cardiac action potential within the ventricular myocardium, similar to that of TCAs. Now, co-administering them should be avoided since it would worsen the QRS widening and would cause risks of malignant ventricular dysrhythmias. I'd like to remind you that hypertonic saline can be used to manage refractory cases of malignant ventricular dysrhythmias from tricyclic antidepressants or when the pH is already at goal. I would just like to remind you that Flexeril or cyclobenzaprine is structurally similar to tricyclic antidepressants, and key treatment goals are to get the QRS interval to below 100 milliseconds and to maintain pH between 7.45 and 7.55. So do not infuse sodium bicarb. It would raise it way beyond the 7.55 mark and complicate issues here. Let's move to the next slide, please. And the question reads, Mr. TBT, middle-aged male patient who has confirmed tricyclic antidepressant toxicity, presents to your accident and emergency department, and your emergency medicine team has initiated fluid resuscitation alongside sodium bicarbonate IV infusion a while ago. TBT is beginning to develop hypotension. He hasn't had any ventricular arrhythmia so far, so my question to you is, which of the treatment options listed below would be the most appropriate in Mr. TBT's case now? Would you settle for urinary alkalinization? Would you administer norepinephrine? Would you do hemodialysis? Or would you settle for ECMO, extracorporeal membrane oxygenation? I'll give you 10 seconds to choose the correct answer. I would opt to administer norepinephrine. Now, norepinephrine can help manage the patient with hypotension from tricyclic antidepressant toxicity, and this is based on a small retrospective study where patients getting norepi responded better than those getting dopamine, for example, and those not responding to dopamine responded to norepinephrine. Now, ECMO can be considered if hypotension doesn't respond to fluid resuscitation, doesn't respond to norepi, doesn't respond to dopamine in patients with tricyclic antidepressant toxicity, but it's not first line, remember that. And hemodialysis wouldn't be effective in the management of tricyclic antidepressant toxicity due to the fact that they have very large volumes of distribution, and urinary alkalinization hasn't been shown to be effective in the management of tricyclic antidepressant toxicity. Let's move to the next question, please. And it reads, Master WPW, a 13-year-old boy, is rushed to your accident and emergency department by his mother after she noticed he swallowed an unknown number of acetaminophen tablets about 4 hours ago. Now, according to a laboratory report uploaded in your hospital intranet, his acetaminophen levels are now 250 mics per ml. He is asthmatic and is allergic, and he uses or inhales PRN salbutamol, and he also uses Advair and Claritin to manage his condition. So my question to you is, which of the interventions listed below would be the most appropriate in the case of Master WPW now? Would you opt to administer N-acetylcysteine via nebulization? Or would you infuse N-acetylcysteine? Or would you administer N-acetylcysteine orally? Or is it true that it's not indicated in this particular case? I'll give you 10 seconds to choose the correct answer. So I would administer N-acetylcysteine via the oral route. Remember, oral N-acetylcysteine should be given to pediatric patients with a history of asthma, since anaphylactoid reactions have been reported with IV N-acetylcysteine. Remember that. And it occurs more commonly in the pediatric population. Now, the risk of anaphylactoid reaction appears to be related to the dose and even the rate of the IV infusion of N-acetylcysteine. Now, slower infusion rates can reduce this risk, but should be used with some caution, especially in patients with the risk of bronchospasms, and you can only opt for this when no other options exist. Now, a paracetamol concentration of 200 mics per ml or above at the 4-hour mark indicates probable hepatic toxicity, so N-acetylcysteine is recommended and should be administered. So that makes alternative D raw. Now, oral N-acetylcysteine treatment is dosed at 140 milligrams per kilo loading dose followed by 70 milligrams per kilo dose starting 4 hours later, and given at 4-hour intervals for a total of 17 doses, 17. Now the entire regimen will take 72 hours to complete, so it calls for a lot of observation and patience. And I would like to add that IV N-acetylcysteine treatment is usually 150 milligrams per kilo in 200 ml of dextrose 5%, infused over 1 hour, followed by 50 milligrams per kilo in 500 ml, infused over 4 hours, followed by 100 milligrams per kilo in a liter of D5W, infused over 16 hours. So the IV infusion therapy lasts a total of 21 hours as opposed to 72 hours when we treat via the oral route. Let's move to the next slide, please. And the question reads, Mr. TPP, a middle-aged male patient, was found unresponsive in his living room with an empty bottle labeled Inderol. He was rushed to your accident and emergency department where an EKG was done by the nurse. It showed a PR interval prolongation and sinus bradycardia. Some of his pertinent labs included elevated AST and ALT. So my question to you is, which of the therapeutic options listed below would be the most appropriate in Mr. TPP's case? Would you opt to infuse sodium bicarbonate? Would you administer glucagon? Would you opt to use orally administered activated charcoal? Or would you infuse calcium chloride after diluting appropriately? I'll give you 10 seconds to choose the correct answer. I would administer glucagon. Now, glucagon is commonly used for overdose of beta blockers due to its ability to bypass normal catecholamine generated influences on CMP and increases CMP via other mechanisms, which has been shown to increase BP. Now, activated charcoal can be considered in immediate release beta blocker overdose, but may not be useful 2 hours after ingestion or in long-acting agents. So glucagon would be superior to it, and there is no evidence for the use of calcium chloride or calcium gluconate in beta blocker toxicity. Just like to remind you that sodium bicarbonate may be helpful in the management of beta blocker toxicity in patients with wide QRS because of its ability to inhibit sodium inward current during phase 4, if I remember well, of the nodal action potentials. Now, Inderol, which is propranolol, is an oral non-selective beta blocker which may have a longer half-life in individuals with liver dysfunction, for example. And I would just like to emphasize the need to premedicate patients with an antiemetic, since glucagon increases the risk of nausea and vomiting. As much as it's the best option here, the patient would vomit, and if they're not very conscious, aspiration and pneumonitis may ensue. So, ladies and gentlemen, my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, please remember to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the best is yet to come. Thank you all very much for viewing and listening to this video. I sincerely appreciate your partnership and your continued support and kind collaboration, and I look forward to be interacting with you in part 73 of our MCQ series. Thank you very much.